Amazing. Thank you so much. I would also like to thank the traditional owners of the lands where I live and work, the Wurundjeri people of the Kulin Nations, which has always been a place of learning and technology. And sovereignty was never ceded. It always was and always will be Aboriginal land. I also would like to extend my respect to all of the Aboriginal and Torres Strait Islander people joining us in the webinar today. So we'll get the party started. This is a presentation based on the first stage of my ARC Future Fellowship project. You will see, and you will have heard from the introduction, that it was initially called Digital and Data Literacies for Sexual Health Policy and Practice. But we have, over the process of the first stage of the project, shifted our focus to capabilities. And I'm going to talk about why we are using different terminology now and what it means, I think, for sexual health workforces. I also would like to acknowledge that this shift to capabilities is built on a range of projects that I've been working on over the past couple of years with my colleagues in the ARC Centre of Excellence for Automated Decision Making and Society. Particularly Professor Anthony McCosker, my colleague at Swinburne University. And over the past 4 years or so, we have been working on a range of projects that focused on building a model of data capability for the not-for-profit sector that was designed through participatory research with not-for-profit organizations and representatives. Those various projects are covered in the book you see on the far right, Data for Social Good. It's an open access book. You can download it. It's led by Professor Jane Farmer from Swinburne. We've also developed a data capability framework for the not-for-profit sector, which is freely available online, and you can Google it again with my name and Anthony's name, and you will find it quite easily, but there's a link at the end of this presentation. And some of the considerations of what a digital or data culture might be, as opposed to some other ways of thinking about digital and data practices, which we'll allude to during this presentation, come from the collaborative work I've done on everyday data cultures, which is led by Professor Jean Burgess, again from the ADMS. And this work is not a solo effort. As you can see, it's also supported by my wonderful colleague, Sam Mannix, who's presenting with me today, and Caitlin Lermouth, who's currently undertaking a PhD project associated with this work. Thank you, Sam. So this project, quite fortuitously, has coincided with the development of a national policy framework, which is intended to I guess, instrumentalize the Digital Health Capability Action Plan, which was developed by the Digital Health Agency in 2000 and is being rolled out through a range of consultations with the sector as we speak. And this is a framework which is intended to upskill the health workforce in the broadest sense, so practitioners, researchers, educators, clinicians, anyone you might think of, to work with data-driven digital technologies in a kind of continuous learning process. We'll have the next slide, thanks. And so there are 2 draft documents being circulated at the moment. They will be finalised and released before the end of the year, we are told. That work's led by the Australasian Institute of Digital Health, but it's led by the Digital Health Agency, the organisation that brought you My Health Record. And the 2 documents that you will see on the slide here are the Digital Health Capability Framework, which is a framework to help members of the health workforce self-assess their own digital and data capabilities. And this is a kind of instrumentalized through a series of I statements that kind of allow people to self-assess whether they kind of have an awareness of a certain issue, whether they're learning to master a certain skill or a certain understanding of digital health technologies, or whether they consider themselves to be proficient or leading in that space. And basically everyone in the workforce will be expected to self-assess against these guidelines at some stage in the next couple of years, and to do so iteratively. It's not intended to be a one-step, self-assess at a point in time and never look at it again. This will be an iterative process. And the supporting document you see on the right explains data and data quality, and why data is important to digital healthcare. And as you will see, what health researchers and health workers do and don't know currently about data came up quite prominently in our first stage of research, and it really pointed to the need for some increased conversations about data. So the aim of my project was to develop specific frameworks, guidelines, resources for sexual health workforces. And this came out of work I had been doing over a number of years. I had no idea there was a Commonwealth framework in development. We are very grateful for that fact. But I was prompted to apply for the funding to undertake this project because over the course of many years, I have been doing a number of projects looking at the ways that digital and data self-representation practices can play a role in young people's, and I use that term very broadly, anyone from 12 to 29 in the health guidance frameworks at the moment are considered young people. I currently am considering young people as 18 to 29-year-olds for the purposes of my research, so young adults, I guess. But I have been looking at the ways that digital and data practices might inform young people's, young adults' understandings of sexual health, again, in the broadest sense, including well-being, and the ways that educators, health promotions, and clinicians engage with these emergent and in many cases well-established now practices of digital engagement as part of people's sexual health, sexual learning, sexual relationships, sexual intimacies. So everything from using dating apps, accessing online pornography, sharing selfies, having explicit chat, getting on Discord to ask your friends, do they know of a good sexual health clinic or where they can get tested in the local area and what kinds of tests they should ask for. All these things I would consider to be digital sexual health practices through the framework of my own research. Increasingly over the past few years, I was invited to work with adults in the space of health promotion or sexuality education. And I was often asked by the adult workforce what they should tell young people about digital health and digital practice. But I began to wonder whether a better question wasn't like, what should you be telling young people, but what do you already know about digital technologies and digital spaces, and what kinds of conversations can you have as a result? So I ran a series of workshops with in partnership with a range of organizations, including True Relationships in Brisbane, Family Planning New South Wales in Sydney, and then the Alana and Madeline Foundation and what is now known as Sexual Health Victoria in Melbourne, where instead of defining what media literacy might be for young people and how it might interact with their sexual cultures or their digital cultures, I asked instead, how do educators and youth health promotion and clinicians as well currently understand young people's digital cultures? How do they rate their own what we might call media literacy and that of their colleagues and peers, and what kinds of training and resources do they have access to, what kinds of theoretical frameworks, what kinds of practical frameworks, and then how are media practices currently framed. At that time, I was framing it in relation to sexuality education. Later, I began to think about it in relation to sexual health. So what are media practices, digital media practice specifically in the kind of space of sexual health? Are they simply risk factors? Often we know they are in the way that the literature talks about them. Are they learning opportunities? Are they a distraction from the real curriculum? Are they a source of myths that needs to be countered by facts? Or we might say now, are they misinformation that needs to be corrected by accurate information? Or could we say it's something else entirely? My findings from those kind of interlocking projects were that even though adults practice all kinds of mediated intimacy, we use dating apps, we send selfies, we ask for sexual health advice online, but it's often framed by people working in youth support services as a site that is exclusively risky for young people. And this was intensified when a new platform or technology was introduced, like, oh God, I just got my head around Instagram and now I have to understand TikTok. Obviously, that's a much riskier platform, in brackets, because I don't understand it. Or when there was a strong reliance on what might be termed a framing drawn from behavioral psychology. So the idea of media as the source of impacts and effects, as opposed to a cultural site. But what I learned in that project was that participatory and practice-based activities with health workforces were a really good method for kind of lowering that anxiety about digital technologies. And it was a useful research method for me, but it was also a great way of engaging with community and industry partners, and making and doing things with social media worked really well for me as a methodology for both engaging with health workforces, but also kind of fostering an understanding of these spaces as a site where they can engage with and dialogue with young people, as opposed to sites that are risky for young people. A lot of this work has already been published, so I'm not going to go into it now. It's the preamble to the project we're doing now. And so when I came to design the present project, we can flick forward now, thanks, Sam. I really wanted to do a bit of a dive into the current literature, because increasingly I was seeing projects being floated by my colleagues in health who were discussing digital literacy or digital health literacy as a kind of a health intervention, if you like, or an element of health interventions. And I was curious to really understand what this meant in a more systematic way. So again, I was curious to see how my colleagues in the site of service provision or the site of health research, how they defined digital literacy or digital health literacy as a kind of portmanteau, and what that meant in their practice, and how they observed what I was initially calling digital or data literacy in that research stage, but what I now would term, I guess, digital or data capability being operationalized in health policy and health practice. So I will let Sam now speak to the literature review and the interviewing we did in this first stage of the project to kind of update that initial knowledge I had from the 2015 to 2017 period, and give a bit of context for what we found there. Thanks, Sam.
Thanks, Kath. Did I unmute myself? Yeah, okay. So as Kath said, to better understand what digital and data literacies mean in the sexual health context, we undertook a social science narrative review, complemented by some interviews with senior researchers and practitioners across sexual health and other allied fields. You can see here on the screen that the literature review consisted of a database search for the columns on the left, with the duplicates and unrelated results removed. We had about 30 papers. There were no results at all with these search terms and data literacy as a concept, but we did sort of get some diverse considerations of data within the literature. So our interviewees were recruited from existing networks, with snowball recruitment continuing until we completed our final interview in March this year. We interviewed 30 people in total also. So you can see here the spread of expertise and experience of our interviewees, which gave us sort of insight into the way that the digital and data literacies, as Kath said, what we were calling it at that time, do or don't arise within sexual health policy or practice and research. So some of our interviewees were across different fields of research as well as sites of practitioner experience. So we're able to give us a really holistic view of clinical experience, research experience, or clinic managerial experience, I guess, which was really helpful. So within the literature, we found that digital technologies and platforms were largely seen as sites or systems for communication or the transfer of medical information and clinical services. So a large proportion of the work was focused on quantifying and measuring individual digital literacy levels. So where digital literacy was framed as a relevant skill or attribute for individual consumers or patients. We also found that the terms digital health literacy or digital literacy or e-health literacy were used interchangeably throughout the literature. So it was also, digital literacy was discussed as a necessary tool to navigate the proliferation of online sexual health content, as Kath has said, which was often defined in the literature as information as opposed to sexual health content, as well as the skills to navigate clinical technologies. So here, digital literacy was associated with sexual health outcomes related to behavior change, treatment adherence, and protection. So, for example, there was an assumption that digital literacy enhances access to information, which will therefore decrease participation in risky sexual behaviors. There was also there was no discussion of sexual health professionals and or organizational digital literacy, other than to discuss the importance of considering digital literacy levels of patients or consumers when developing sexual health interventions or messaging or clinical services. And as I said earlier, there was no considerations of data literacy as a concept in relation to sexual health. So considerations of data did arise in relation to accessing and understanding electronic health records, where these kinds of skills were considered to be related to data literacy. So in our interviews, as Kath mentioned, one of the big questions, I guess, arising was around what is data for sexual health? So considerations around the way sexual health organizations and practitioners access or understand and utilize different types of data. So in some instances, data organizations did not recognize themselves as generating data beyond the space of clinical practice, such as Medicare data, despite using data-driven enterprise platforms and technologies in health promotion, education, and client management activities. So that might be website tracking data that is kind of collected by Google without, any say from the organization. So thinking about what that might mean for sexual health. Participants spoke about the way expertise and experience, both organizationally and disciplinary. So whether it's clinical health or health promotion, or data management or marketing was often siloed, and identified a need to develop collective and interdisciplinary approaches to digital and data practices. A lack of resources were also identified as both a barrier to external collaboration and a driver of reluctant participation in external projects as a price of accessing analyses of internal data. So we might not have the capacity to analyze and access the data ourselves. Therefore, we have to participate in a broader research project to gain access to what this data means and some of that analysis. Participants spoke of concerns around digital and data governance structures and accountability. And this again really spoke to the need for organizational approaches and policies that recognized decision-making processes and ethical principles, for example. So, you know, there are examples of not really knowing until something bad happens. So how can we kind of preempt some of these questions before we have to respond to a crisis, for example, or a data breach? Again, a need to work with young people and or co-design processes to better understand and incorporate their sexual health, digital and data practices within organizational policies and knowledge systems. So it was sort of about recognizing that young people may have expertise in these areas, and how can we not take that expertise but learn from that and embed it within our organizational approaches. And luckily this really aligns well with the next stage of our project, which we'll come back to, I think, at the very end with a bit more information. Back to you, Kath.
Yay, thank you. So you'll see basically from Sam's whirlwind presentation there that we found a bit of a gap in the literature around defining digital and data literacy. And at the same time, as I said, I had been working on a number of projects which moved away from a focus on literacy and in fact problematized the notion of literacy and were leaning instead towards the notion of capability for a number of reasons. Some of you may be quite familiar with the debates within the space of health literacy around the project itself, I should say the term itself. Health literacy is certainly a term that's considered to have a bit of baggage. There is a bit of concern that it is often used to focus excessively on individual deficit or to redress or remediate individual deficit, and that there has been very little attention paid in some spaces to the responsibility of health organizations and systems and structures to create a kind of health literate culture, if you like. It's a site, I guess, of health consumer deficit as opposed to a site of cultural competence in health. And this concern around the space of health literacy echoes broader conversations about literacy from the spaces of education and linguistics and cultural studies, the home that I was initially schooled in for my undergraduate and early postgraduate training, where literacy has been problematized as a way of enforcing class boundaries. So Richard Hoggett, for example, wrote in 1956 about the ways that literacy studies and literacy education in Britain was used to dismiss the low or vulgar mass media tastes of the working classes and prioritize the more rarefied pleasures of the upper classes, and a way of cementing those class differences by building a kind of political line around particular kinds of literacy that reinforced social capital and economic capital. Annette V, who's a literature scholar who has researched more recently the drive to teach young people to code or to consider whether digital literacy should be considered a core component of literacy, has also reflected on the history of the drive to improve or increase our literacies if you see or reflect on these arguments, it's very clear that it's not just that there's a bit of vagueness around what literacy is or what it does in relation to digital health. There's a little vagueness around literacy more broadly across all the disciplines. As she says, there is little contemporary or historical consensus on what literacy is or what kinds of skills one needs to be literate, and thus, as a morally good but undefined concept, literacy can serve as a cipher for the kind of knowledge a society values. And as she says, workplace literacy is advanced, it's championed. Often members of the workforce may feel shame around a lack of literacy in relation to particular technologies, software, hardware, or kind of emergent digital practices in the workplace. And certainly when we were doing the work with the not-for-profit organizations, we coined a term called data shame, because so many people in our projects, when we were interviewing them, apologized for their lack of understanding of data analytics and data systems. Oh, I'm not very good at Excel, or I can't really use data properly. I know that we could generate more insights if only, I knew. And so there's a sense in which, similarly in health, there are many people who are very, very good at their job and are very well trained and very competent, but are functionally illiterate in relation to some of the tools that they need to use. And as V puts it, it's not that these people have lost their literacy, but that literacy, as it's defined in their workforce, has moved on without them. And as I thought about this and thought about the other projects that we'd looked at in relation to capabilities, I became increasingly uncomfortable with the idea of literacy as a site where people feel a lot of shame and a lot of deficit. And it didn't seem to be the most positive or encouraging framework to use in relation to our project, which is focused on thinking about how can workforces feel more confident and capable in relation to digital and data cultures, including what might be termed vernacular data cultures. So not just the kind of enterprise technologies they use, but the kinds of digital technologies that contact tracers might use, for example, where having a very good understanding of Grindr and online messaging is essential to the job. Thanks, Sam. We'll have the next slide. So why use this term capability instead? Well, Anthony McCosker led this conversation on a previous project, and I tried to set it to one side during this project, but decided it was indeed the best term. And that's because capability is a much more expansive term than literacy, particularly when we think of the cross-disciplinary or interdisciplinary work we might do when we break down silos and begin to work with our colleagues in IT, in data science, in marketing, in those fields that work very closely with data. So in data science, capability can have a double meaning, relating both to the personal attributes or abilities of an individual, but also to the technical components such as software, hardware, and database systems, a combination of tangible and intangible elements that underpin the creation and use of data. And in the project that Anthony McCosker led and in the present project that Sam and I are working on, we retain this double sense to account for the interrelated human, social, and technical dimensions of digital and data capability. And to explain how this might work in practice, we had one of our interviewees who talked about wanting to use social media as part of her work in health promotion, but being unable to do so because her organization had a firewall which didn't allow her to access, we'll say for the sake of the example, TikTok through the IT system that she had to work with for her job. Her not being able to use TikTok for her work was not an outcome of a lack of literacy on her part. She knew exactly how to use TikTok. Her organization didn't have the capability that allowed her to use it. And that's why we're thinking about capability, not literacies in this project. So I will take us to the model and talk us through, and then we will have plenty of time to discuss and answer your questions after that. So we are drawing on the data capabilities model developed in the research with not-for-profit sectors, but Sam and I have adapted it with the help of our project reference group to apply more directly to sexual health workforces. And we've expanded the data capabilities framework to also encompass digital capabilities, because many people who are using a vernacular digital platform, for example, Grindr, are not necessarily thinking about that as data or the production or use of data. They're thinking about that as digital. And that's why we separated out digital and data capabilities for the purpose of this project, although, of course, they are interrelated. This is a abridged or compressed map of our framework. We have a more expansive model in our project report, and we are hoping that it's a model that can be used within sexual health organizations as a means of developing organizational strategy. And we're talking about 3 areas, as you can see. So we're talking at the top of your screen, we're talking about capabilities related to access and infrastructure. What are the digital platforms or data platforms used within an organization? Do you have the technical means to manage them and make use of them? And when I say you, I mean a collective you. Use all in the organization. Do you have the means to access them and manage them collectively? So what are your enterprise platforms and systems? What are the tools you're using? What are the vernacular platforms and technologies that you're also using? Perhaps Instagram for outreach and health promotion. In your organization, what do you count as a digital sexual health platform? So would you say Instagram is a digital sexual health platform? Some organizations would, some wouldn't. And how do the technologies and platforms you use support organizational purpose? And then when we talk about data, what are the systems and tools you're using? What's their interoperability? What counts as sexual health data in your organization? How do you use it and access it? Those kinds of questions. At the next level, then you have skills, and this is where the individual, I guess, is more the focus. The ability to generate, read, write, appraise, analyze, use digital technologies and data. And that would include understanding things like platform analytics. So are you focused, for example, on your Insta page? Again, I'll go back to Insta account. Are you focused on clicks and likes? Do you care more about comments? That's a kind of expression of digital capabilities if you have a reason to focus on one or the other, and you can explain why. In terms of data capabilities, you might think about your ability to, collect data, clean data, understand how you use data. Can you gain insights from your own data, or do you need someone else to clean it and provide the insights for you? Those kinds of questions. There's not a right or wrong answer to any of these, by the way. It's a means of kind of problem posing to understand where your organization is in relation to digital capability or data capability. Finally, we have the area of governance. And actually, most health organizations, I will say, are very across governance, because there are top-down compliance issues in relation to governance. So you will most likely have established processes of stewardship, leadership, and accountability. But there are some cases where this might not be the case. So, and we've seen in relation to both the Optus data breach recently and then the Optus outage that organizations, even large and very well-established organizations, may be at risk in relation to their data, and that there needs to be a policy framework, but also a kind of practice model across an organization that is accountable for data. And one of the other things we would say in relation to questions of data sovereignty is organizations might also think in relation to data, how do the communities that we serve influence the way we understand our data? Do they have access to our data? Can they help us make sense of data if we work with them collaboratively? So that's one of the questions we're asking as a kind of prompt for developing data policy or data strategy. How does lived experience inform decision making around our organization's collective use and storage of data? Thanks, Sam. Next slide. So that is a whirlwind tour through stage one. Obviously, we have some work in progress to share, both the academic side of this initial stage, but also to begin to work with organizations to consider how the questions that we pose and the digital and data capabilities models that we've developed can work on the ground for developing digital and data strategy. In the next stage, we are going to do some co-design work with sexual health consumers aged 18 to 29 to look at the ways that digital and data capability is understood in that kind of vernacular everyday practice way by people who might be accessing health services or seeking to avoid accessing health services by using an app instead. And from there, we will be developing and piloting some information and training resources for the sexual health workforce. We are very enthusiastic about talking to organizations or individuals that would like to work with us on this front. And we also are really interested in the next stage, and we will be working up a short piece for the journal Sexual Health on this front to think about how our model really articulates with those Commonwealth frameworks. One of the things that's really clear to us is that the Commonwealth framework, and I totally endorse this approach, is a kind of self-assessment model. I am concerned with this. I have competency in that. It's not really a model that's designed for collective decision-making around digital and data capability, although it does talk about the need to do that. It doesn't provide guidance for doing that. So I think, and also it addresses sexual health, sorry, I should say health workforces more broadly. It doesn't consider the kind of distinctiveness of sexual health in relation to issues like stigma, for example, and barriers to access. So this is where I hope that our work can complement that broader policy. So just to kind of sum up, we have moved to capabilities because literacy is so often framed as a deficit, and it's so often framed in the sexual health literacy as a deficit for the consumer. And there is a bit of a silence around workforce literacy. But also, as we know, literacy is a very classed, very loaded term. It has a lot of baggage in relation to workforces. So as Annette V says in her work, you know, it's really interesting to consider which workforce skills are considered to be literacy and which are not. She said, you don't often say, oh, my hairdresser is so hair literate, but you might say someone who works with data is very data literate. So there's a kind of hierarchy of literacies. And to date, capabilities hasn't really been talked about in the same way. So I am embracing it as a space with less baggage, less heavy historical baggage associated with it. And also, I would say that capabilities is a good place for us to be working as cultural studies or social science scholars, working with our colleagues in health who have a more hands-on role, because a capabilities approach has a kind of strong history in social science and other forms of thinking as a kind of a side of social justice. So the work of Amartya Sen and Masha Nussbaum, where they talk about a capabilities approach as a way of acknowledging and foregrounding what might be termed agency in health or in other spaces. That seems to me to be a really asset-based place to be working from when we consider ongoing training and development within a workforce that is pretty stressed, pretty under-resourced, pretty exhausted, and similarly, the health consumer could be said to be in a similar place after COVID. That is our 40 minutes of presenting. Many thanks to our project reference group. Some of them are here today. I have a list of references here on the slide, but if it is too teeny tiny, please email me and I'm happy to send it through to you. And now Sam and I would be really pleased to open up the conversation for the final 15 minutes of this forum. Thanks a lot.
That's excellent. Thank you so much for that. I'm going to invite people to turn on their cameras if they so wish. There's no pressure, but you can if you like. And that if anyone had any questions, you're welcome to raise your hand or pop it into the chat. I want to just say, health literacy is not my area, but when in the times that I have come across it, I've been struck by the lack of definition. And so I'm very intrigued to see that this is not just me struggling in this space. So that was really insightful. And I really loved the quote that you shared, and I think it was from V, around individuals may not necessarily lose their literacy, but literacy moves on without them. And I think there's so many settings where that's applicable, and people who may be disengaged from digital technologies for some time and come back to them, or be in settings where there's not great access to internet or other digital capabilities. It's really empowering to them that it's more circumstantial rather than individual ability.
Yeah, and it's not that we would say throw away literacy; it's meaningless. It still can be a useful term, but but in the space of health, and it's interesting, the new capabilities framework uses this. It seems to be much more, can you use a particular software package? Can you identify a fault in this system and report it accurately? And it's not really thinking about that kind of broader multidisciplinary systemic approach. So, and that's again where we think capabilities is probably the better term to use in relation to the conversations I think we increasingly need to have about the digitization of health practice and service provision and health research and all of these other spaces we're engaged in.
I would just add to that there's been a lot of definitional, whatever that word is, work around health literacy, trying to kind of make the I guess definition or the concept more attuned to the complexities and the nuances of different contexts and things like that. But the application of it still relies upon those individual skills or measuring those individual skills. And so then kind of misses a lot of the complex things that Kath mentioned. So part of that kind of move to capabilities is again kind of losing that baggage of we're just going to measure these individual skills and knowledge, but we're also going to kind of ask those cultural questions or organizational questions. So I think there's a lot of work around trying to define the concept of health literacy or digital literacy, but it kind of still relies upon measuring something that's measurable, and those more complex things aren't as easily measured.
Anthony.
Hi, Kath. Hi, Samantha. It's lovely to follow along with this project. It's exciting. I'm curious about where sort of labour practices might fit in with capabilities. I'm not as familiar with with the kind of national plan. But yeah, if it fits into your thinking or in the like stakeholders you've interviewed so far, like as in like who's actually doing this work and how is it factored into how people are paid and the time that they perform in their jobs? Because there's lots in the literature about how digital health innovations might save time, but then they also often cost people a lot more time to clean and manage data.
Yeah, so the capabilities framework hasn't been released yet. We are working off the drafts, but it is top down, bottom up. Every workforce, every university, every training course, like it is going to be everyone from what I have seen. And it is just going to be presumed to be part of the job, although not everyone is expected to work with data. The understanding in the policy documents that we've seen and in some of the literature that I've seen around medical educators talking about how they're restructuring degrees, it's very much about in the short term a bit of an upskilling, so that the running short courses on health informatics to upskill the existing workforce, but then rebuilding undergrad degrees and kind of foundational training and the kinds of accreditation processes so that everything includes digital and data practices explicitly. That's what I can see. And I don't imagine it's going to be like, oh, we've released the final report now, you've got till September to get this done. Even the frameworks make it very clear that it's an ongoing process and it's an iterative process. And they say, we use capabilities because this isn't about measuring a point in time and then saying, right, you're done. So and there's been a lot of consultation, I think, with unions and other leadership groups in health and advocacy groups. So but yeah, it's extra work, but it's also it's here and it's happened. It's already been happening, and part of my frustration and the reason I went into this work was I felt like there were a lot of organizations that were maybe in a little bit of denial and hoping, for example, that Facebook would go away so they didn't have to deal with social media or those kinds of things. And clearly, Facebook now is not the youth demographic, but social media hasn't gone away. And everyone is now going, oh, and AI for health, what even is that? So it's and capabilities takes us away from I have to understand every single platform to I am working in an evolving space where digital technologies and platforms are going to constantly evolve through my working life. Yeah, and that's why we move from literacy to capability, because yes, literacy moves on without you, but you can upgrade and engage with capabilities throughout your working life. Ideally, that's my pep talk, I hope. Yeah. I think Joanne has a hand raised, but
I'm just gonna peep over to Karen real quick because Karen's
okay. Yeah, sorry.
To the chat. Do you want to ask your question, Karen?
Oh, I'll be really quick because I think Joanne's probably got a better question than me. I was just struck when you talked about the strength-based approach, and I love the reorientation from a deficit to strength-based, and also the distinction that you are making, but also the links between digital and data capabilities. And I just came back from Heather McCormack's amazing seminar as well, talking about First Nations sexual health and strength-based approaches. And one of the things that struck me, and I was just wondering whether there were some thoughts you had on it, was the connection with that and data sovereignty, not necessarily just for First Nations peoples, but just more generally how data capabilities feed into data sovereignty.
Yeah, I mean, that's one of the things that I think is most salient in relation to sexual health, and a little, all our health data, there needs to be consideration of data sovereignty. but particularly in relation to sexual health data. And one of the things that I need to articulate and draw out more, but I have another project that's focused on sex tech. And there are many, many developers and private companies around the world who have pitch decks that they are very happy to present you about how, oh, you don't really need to worry about publicly funding sexual health anymore because venture capital will save us all by giving us an app that allows us to manage this, that, or the other element of our sexual health. And actually, what that involves is entering into a network of data brokerage and giving your data to a private company. I don't always feel comfortable giving my data to the government. To be honest, I did not opt into my health record because I didn't trust them to look after it. I'm sorry if anyone from the Digital Health Agency is here. I'm sure you know it's much better than it was when you first launched it. But yeah, I think that's a very real question, and there are many sites where it's very clear that that kind of old blunt metaphor about data being the new oil is really what's underpinning the commercialization of certain kinds of sexual health related technologies. And yeah, and data sovereignty is an issue for sure. Joanne, I'm going to you.
Hello, and thank you. Great project. I mean, I love the idea of capabilities, especially compared to literacy, which, I mean, I totally agree with everything you've said about the problems with the concept of literacy, although it does have I guess practical value in how it helps people to know how to do their work. That's a useful thing. But I do love the idea of capabilities. I think it reveals the way that it reveals how people come to know about sexual health is a political process. And I think it's an excellent tool to apply to that. So love that. My question is about, and now that I've thought about this question a bit more, I think you might have answered it already, but my question is whether there's a third phase that will maybe not necessarily evaluate the framework, but look at how people actually use it in their everyday practice. I think that would be fascinating.
Yeah, so after the co-design, we will pilot some resources with any health partners who might like to do so, as many as we can manage in the time available. So we have some organizations already with their hand up to help with that. But yes, we will do a short-term evaluation of how people use it in practice. We're also already talking with an organization about their plans to redevelop their digital strategy and how they might take our capabilities framework and use that as the foundation for conversations among their leadership and staff. And that's something that I wouldn't necessarily impose on organizations, and particularly the reason that we've used it as a kind of offered a question posing model as opposed to a series of statements is that we would like to see the capabilities framework as a series of prompts that people can use in practice. But yes, by the end of the project, or at the end, January 2026, we hope to be able to say something, however early days it is, about the ways it can be used in practice and the ways Australian organisations or international organisations, if that's who turns out to pick it up, might use it in practice.
Thank you so much, Kath and Sam. This has been a fantastic seminar and really informative. I think everyone's gotten a lot out of it today. So we will call it 3 minutes early, everyone. But thank you again. Have a good afternoon.
Thanks for having us.